For everyone with an interest in MASH or, more broadly, steatotic liver disease, Surf's Up. Surfing the MASH Tsunami's annual year-end interviews with some of the people who made a difference in the MASLD world in 2023. Season 4, episode 50 plus starts now.
Today on Surfing the MASH Tsunami.
Well, I got 2 words for you on that. It's inclusivity and solidarity. And I say this from 2 points of view. And it's interesting being a physician and working in a patient advocacy organization. Because from a physician point of view, you think about provision of services. And from a patient advocacy side, you think about the receiving of services and where the twain shall meet.
First of all, thank you for bringing up stigma. I call it a tower of shame that starts to happen within an individual that just keeps on building up. And to break down that shame, if you're telling someone to lose weight or just do this or just do that, or you have the fear of sharing how much you're drinking because you're afraid of losing your employment, your kids, your friends, being berated, and that shame is very deep.
I was going to tie in what Jenn had said earlier about being really ill. It's a frightening stage to be at. And in hepatology, we are a team. We are the doctors, the nurses, the healthcare workers, down to the receptionists who know all of our patients, because we know our patients very, very well. They may not see a hepatologist every year, but the nurses will always keep in track.
At least in the US, the primary care practice is incapable of doing the kind of quarterbacking that you're talking about, right? You've got a 6 to 8 minute appointment contact, as you point out. Usually, by the way, we've got a 12-minute questionnaire, right? So if you speed talk and take all your answers in yes and no's, you might get it done. And without a lot of structure behind it, it tends to fall apart.
I think technology is an incredible tool that assists us in many different ways, but in and of itself, it isn't a solution. At the Fatty Liver Foundation, for example, we've set up the Wellness League, which is an online portal where people can get on, have access to various services based on their zip code, find peer support, as well as everything from recipes to how to live a healthy diet, etc., etc.
As a momentous year in steatotic liver disease comes to an end, the Surfing the MASH Tsunami team is reviewing the year with some of our favorite guests. Today, liver health advocate Louise Campbell and pricing and forecasting guru Roger Green interview patient advocates Neeraj Mistry, Chief Medical Officer of the Fatty Liver Foundation, and Jenn Leigh Jones, founder and board chair of the Society for Sober Liver Survival, on the merging of their organizations and what it says about the future of patient advocacy on the Surfing the MASH Tsunami podcast.
Today we're here with 2 first-time guests to the podcast, Dr. Neeraj Mistry, who's an advisor to Fatty Liver Foundation, and Jenn Jones, who is the founder of the Society for Sober Liver Survival, which it's taken me a while to get my mouth wrapped around, and I'm usually pretty good at tongue twisters, Jenn, so I think you've really outdone yourselves with this one. Good afternoon or good morning to both of you. Neeraj is in Italy today. Jenn is in Colorado. Good morning, Jenn. Good afternoon, Neeraj.
Good afternoon.
How you all doing
Well,
today?
thank you.
Good.
So when we have someone on the podcast for the first time, we ask you to tell us one thing about yourself that we wouldn't guess if you didn't tell us, okay? Louise, Jorn, and I have done this more times than we care to admit, so we're not going to do it on this round, but you two are. So brave one, go first.
Go, Jenn.
You just gave us a clue as to where you might want to go with this.
Right. Yes, that's actually true. I worked in aerospace for 5 years, and I actually worked on the first time that the Orion contract went out and went to Lockheed Martin. We were one of the small businesses that won that subcontract, and I also got us our first direct contracts with NASA Glenn Research Center, developing a Mars flight software simulator, which was an airline flight over Mars, and it's an educational simulator to get kids excited about space, because STEM technology is one of my favorite points, is helping kids with science, technology, engineering, and mathematics. But I'm not an engineer. My father is.
So if you wanted a liver advocate, that's really an interesting background to come from. That's fantastic. Okay, Neeraj, pop that.
Well, I guess in my I wouldn't say totally youth, but before I became a father, I was a bit of an adrenaline junkie. And so everything from climbing Kilimanjaro to sort of going trekking in Thailand to the Amazon, riding across India in a rickshaw, that's the type of thing I used to do. One adventure a year. And then went went into adventures in parenting. So
I was going to say parenting, particularly young parenting, is one adventure an hour, right?
oh yeah, absolutely.
Yeah, fantastic. How many children do you have?
I've got 3, 14, 11, and 9.
Oh boy, you're in for more fun than you know what to do with.
Good luck.
And
Louise and I are on the late side of this one, and Jorn is way behind you in terms of children age. So.
And this whole TikTok, Instagram world that the kids are growing up in, it's just a whole other realm.
They got the TikTok.
Yeah. When I realized that the word of the year was a word I'd never even heard, like slang I'd never even heard, Riz, they've got this really funny thing of interviewing baby boomers about what does Riz mean. And nobody gets even close to it. With all that, why don't we dive into our content portion of this conversation? So to start, Jenn and Neeraj, before we get into your specific, I want to take a look at the liver community, this SLD, the MASLD community, or the SLD community in general in 2023. Give us a word or phrase that captures how you feel about the last 12 months in the liver community, in the Steatotic Liver Disease community, and then what it is, why you chose that word or phrase.
Well, I got 2 words for you on that. It's inclusivity and solidarity. And I say this from 2 points of view. And it's interesting being a physician and working in a patient advocacy organization, because from a physician point of view, you think about provision of services. And from a patient advocacy side, you think about the receiving of services. And where the twain shall meet, well, that's the sweet spot of impact. And so when we think about inclusivity and solidarity, it's for liver disease, which was a marginal issue compared to all the other issues, heart disease, AIDS, TB, malaria, etc. And so when we've created this year this SLD umbrella, we started saying everyone in the liver camp gets together and vocalizes and advocates for their issue under one umbrella. And I think that is sort of the 2 words that capture it for me, inclusivity and solidarity.
So for our audience, Neeraj just gave you the theme of the entire episode, or the entire interview, brilliantly encapsulated. Thank you, my friend. Okay, Jenn, your turn.
Neeraj, I don't know if I can top that, because that is just fabulous, because I completely wholeheartedly agree with what you just said. The term that I would use, because it's a mantra that I say all of the time, is amor, fati. Friedrich Nietzsche came up with this term, a German philosopher. Actually, I think he's Austrian. And it means to love a fate. If you have liver disease, especially if you have steatotic liver disease caused by any of the toxins, whether it's food or alcohol, you have a story to tell, and it happened for a reason. So no matter good or bad or indifferent, loving your fate and loving and learning from it is what's going to help us as advocates as we move forward. And so it's not to forget the past, but to learn from the past so that we can make a bright future.
That's fantastic. I think you two have bookended the best of patient advocacy, and really, I think what your organizations are trying to do brilliantly well. So, Jenn, you mentioned that you had a allegory you wanted to share with us. Why don't we start there?
Well, in 2018, I was a turtle in a toxic sea, and I'd become very diseased with alcohol-induced hepatitis, alcohol-associated decompensated cirrhosis, and I had very, very little chance of living. So I climbed up onto the beach and I thought I would die. But instead of dying, a miracle happened, and the doctors at UC Health saved my life, and I began to heal. And as I began to heal, I started using those flippers and started flipping towards the first tree that I could find for some shade, trying to discover if there was anything else I could do besides staying away from that poison sea to make me better. And along that journey, I met Dr. Vijay Shah. He was at that tree in the shade, and he said, I don't have a treatment for you, but you are eligible for something. You're eligible to become an advocate. And with that, I grew legs, and he pointed me in the right direction, but he pointed me up this huge mountain. And I didn't know if I could make it, but then I heard this calling that said, do not be daunted by the world's grief. Do justly now, love mercy now, walk humbly now. You're not obligated to complete the work, but neither are you free to abandon it. So I continued to go in these small steps, which means well-being is realized by small steps, but it's truly no small thing. And that's what philosopher Zeno said to us, the founder of Stoicism. And as I reached the top, I realized I was at a cliff. And next to me was this wise owl. Her name was Lorraine Steele. She's the CEO of the American Liver Foundation. And she said, look out there and look at that sea you came from. There's still so many turtles that are dying out in the sea. You need to take a leap and you need to go to them. And I wasn't sure, but in January of this year, I took a leap and couldn't believe it, but I flew. And I started to fly towards the sea, but as I was flying towards the sea, I saw it getting bigger and bigger than I saw when I was at the cliff. And there were so many more turtles than I thought there were. And so I stopped at an island and I saw another tree, and I looked up in the tree and there was this nest of eagles. And that was the Fatty Liver Foundation. And that's where I met Wayne and Neeraj and Henry and Matt and Tiffany. And we all looked upon this sea together, and we had a realization, as Neeraj said earlier, basically, this is one huge disease, steatotic liver disease. And even though each of these turtles are drinking some different poisons, they're all getting stuck with cirrhosis and getting sick with cirrhosis. So we decided to join together and fly together because we knew that we were stronger together, and together we had the equipment that could save potentially a lot of lives. And that is really what brought us together. Is I decided I can't do this alone. No one should have to do any of this alone, including the patients. And I am just so thrilled and so thankful that I found the team at the Fatty Liver Foundation and the robust experience so that we can really make a difference. And there's my story about a turtle that can fly.
Yeah, I was trying to visualize the flying turtle metaphor. I mean, it almost feels like a children's book. So, Neeraj, tell me the story from the other side of what does it motivate you all to come together?
It's really interesting. Oh, and by the way, there is a book with a turtle floating through space. It's Terry Pratchett.
Okay, great. Somebody's already stole my idea. Oh my gosh. No original ideas.
So, one of the things we like to say is it's many etiologies, but one journey. That is the patient pathway. And patients essentially need care, support, treatment access when available. And for those who are at risk, we need preventative intervention. When you look at liver disease, whether it is a collection of comorbidities that result in metabolic disease and metabolic syndrome, to diabetes, hypertension, high cholesterol, alcohol use, or combinations thereof, irrespective of which pathway it was on the collection of risk factors, at the end of the day, patients develop fatty liver disease, they develop fibrosis, it moves on to cirrhosis, risk of hepatocellular cancer, and then liver failure, putting them on a transplant list. And the rate of acceleration through these paths may be different. The genetic predisposition may accelerate it in different ways, but essentially it all converges on the liver. And so for us, it's about how do we prevent people moving down that path of advancing pathology. And if they are on some path that is going to go down towards more advanced pathogenesis, how can we halt that progress and how can we even reverse the pathology that they have? And what we found is those interventions that are required for patients, irrespective of their etiology, is pretty much the same. It's lifestyle, it's diet, it's addiction, and there are many types of addiction that we're dealing with liver disease. It's addiction management, it's social care and support, and when available, treatment that we can offer patients. So it's all of that is similar and is common in the patient pathway. And so when we looked at that, we started saying, well, for us to get the greatest resonance and amplification of our message, we need to create this echo chamber across all the disease issues. And that's where we thought it makes sense. And we took advantage of the nomenclature change, creating this unifying umbrella to sort of bring all the voices together and create as loud a voice as we can on these issues.
So that's fantastic.
Can I add one thing to that, Roger?
Sure, go ahead, Jenn.
The other thing that we have in common a lot of times, no matter where it came from, is a lot of anxiety, a lot of depression, a lot of mental health that we're dealing with, regardless of how you got your liver disease. A lot of times there's going to be some mental health that we need to have an understanding of and help people with.
Louise, I'd love to hear how all this strikes you.
I just love listening to the stories and the journey. What comes across is it's all a journey. We're all on a journey, and at times we interact. So Jenn's journey has now interacted with the Fatty Liver Foundation, with Neeraj. Obviously, we've interacted with the foundation on the podcast before. Neeraj struck me by saying inclusivity and solidarity. And I think that's a beautiful term. I think I've come across from the medical side and in nursing of trying to set groups with patients with liver disease. And there is not necessarily from their side the same inclusivity and solidarity about who will sit in the room with different types of diseases. I used to have a big population of viral hepatitis who were sub-Saharan African and epidemiologies that were native to having those diseases from birth. They had a different take on patients who were from a European background who would have got it through different use. And therefore, nobody could come across the same conversation, but even though they had the same liver stages and the same with alcohol or with other causes. So we found a little bit of the barriers with that. So I find what's happening now because of the generic term of MASLD and what's going on here with the combination of you two organisations and things, I find it fantastic. I think it's enlightening. And I think it is the driver for people to become inclusive. We're stronger together, and nurses are the patient's advocate. So you add the nursing voice to the patient voice and you immediately double the strength of that voice. And we're yet to look within charitable organisations to strengthen the nursing side and to use it. We still try and stay patient organisations, medical organisations, and somewhere in the middle there is a whole voice that has yet to be really empowered to work with the charitable organisations like Fatty Liver Foundation, GLI, and things like that. So that's where I sit in that whole strength of this combination. We are stronger together, and I think that was the phrase used at the AASLD meeting. So everything they've described, I love and would actively support and promote, as you know.
Yeah, I do know. So I have a couple of reactions listening to all this. First of all, there's a funny thing about stigma, which is a term we all talk about a lot, which is that one of the unfortunate effects of stigma is most people who feel stigmatized look for someone who they feel should be even more stigmatized than they are. It's what dominates all kinds of negative and prejudicial politics. And in this case, I think it goes to what Louise just said, but you could see people whose issue was alcohol related looking at people whose issue was diet related and saying, I don't look like that. And people in reverse saying, well, I don't have that problem. I mean, I remember at AASLD last November when they rolled out the nomenclature tentatively that the panelists from India said, oh, no, don't use the term non-alcoholic. Non-alcoholic is the best thing for India because in India, if this was an alcohol disease, that would be stigmatized, but non-alcohol, all of a sudden you're okay. So the cultural issues and the way that stigma affects patients' ability to see that it's a common struggle, it's a high bar. And for you folks to attempt to scale it, reach over the bar, hold hands, and try to bring the wall down, or at least lower it, is, I think, really fantastic, number one. Number two, our last discussion this morning, although I don't know if this is the order in which these interviews are going to roll out, was with Hannes Hagström, who's been, through their work at Karolinska, has been strongly advocating for a while to take a look at the idea that what we've described as non-alcoholic, what we've described as alcohol-related, and what's now called MASLD are, in fact, diseases that have to be thought of in the same context. You know, and one way of looking at that, and I've had hepatology KOLs tell us, well, they're not really the same disease. You know, the liver doesn't look the same. But these are diseases that are behavior-based. And you're right, the behaviors are all addictions. Look, I live with a stress eating problem that I more or less have under control. The two of you don't know this, but Louise certainly does. At one point in my life, I was 50 pounds heavier than I am right now. And it's a struggle to stay here. And I've been having a rough couple of months, and I put 5 pounds on that I have to take back off. But I can stop it at 5. 20 years ago, I couldn't have stopped it at 5. 20 years ago, I would have gained 30 pounds before I even thought about it. So these are all those behaviors. And yeah, you're right. We are all on the same side here.
Roger, can I just add to that? Stigma is a really, really complex thing. And I think one of the biggest challenges we face is not so much the stigma and discrimination that others have toward someone, but it's the self-stigma, where there's this examination of what is wrong with me, what have I done to myself, etc. And what you're talking about is those social risk factors that create the situation where a person starts going down a particular path. And once those behaviors are set in motion, it's very, very hard to break that. I mean, eating fried food is an addiction. It becomes a physiological addiction, and it's very hard to break. And so are nearly every other behaviors that we have. And so once that sort of self-perpetuating cycle starts, it's very hard to break. And that's when we need to rally together with peer support, with education awareness programs, with psychotherapy and counseling, and changing the social environment of people that help break that cycle. And I think it's when we start looking at this together that we can start getting our head around this and making those changes.
Just to support that, Neeraj is right, because when we interact with patients, when we locate disease, the first thing we don't do is talk about psychology. The first thing we don't do is talk about support networks. The first thing we don't do is how are we going to address the behavior change that's often 30 years in the making. The common phrase, eat less, exercise more. We know it doesn't work, but we know it's a common phrase in areas. Moving away from that and targeting the support and the help first, then comes the enlightenment, the change, and the engagement in care. But we have it the wrong way round in a lot of areas because it's been set around this paternalistic way that medicine is delivered. We actually need to stop the treadmill, reevaluate what we're doing and how we care and provide it, then jump back on at a slower pace in the right order. Because if not, we keep bumping into ourselves on the way. Things will fall off that are really good. Things will stay on the conveyor belt that are really bad. And we just walk around them, but they stay there and somebody else picks them up. There are opportunities, and I'd be cautious of going too fast, but not fast enough, but looking at what's really good. And I think we had that conversation with Hannes about each area might be very specific for their own needs. That may be more labour intensive to do initially, but more cost effective and provision of better care in the long term. That for me, it's always about better care, better location, earlier diagnosis, opportunities to strengthen the individual to make those changes. We don't talk about that early enough in the journey that everybody's on.
Louise, taking that and Neeraj's comment, I'm reminded of an interview I did with Zobra Younossi as part of our ASLD coverage about the work that they published on stigma. And there were a couple of things that I think are important here. First of all, it's noteworthy that fatty liver is not a particularly stigmatizing term to patients compared to obesity, diabetes, a few of the others, but can be highly stigmatizing to physicians. And if I think back to my own marketing research work, when I was in that space, we knew that when we did studies on diabetes, we would encounter, if we dug deep enough, real physician hostility towards patients because they know what to do. We know what they should do, but we can't tell them, so they hear and then do it, which goes to point to the idea that nobody went to med school to be a psychiatric social worker. In fact, if you've got the skills to be that kind of listener and have that kind of touch, medical school probably is not what you did. So we've got this system where, Louise, what you're calling for from the providers is not the area where the doctors have strength. And the bias is, the stigma is not only on the part of the patients, but also significantly on the part of the treaters. Louise has persuaded me over the last 4 years, and it's the reason she can't leave this podcast, that a lot of the answer lies in allied health professionals and in the idea that caring is an art and that there are people in the healthcare system on the provider side who understand the art of caring. They just don't tend to happen to be physicians. I wonder if, Neeraj, Jenn, you'd like to comment on the role that allied providers play, A, with your organizations now, and then B, with your vision of how care should be delivered.
First of all, thank you for bringing up stigma. I call it a tower of shame that starts to happen within an individual that just keeps on building up. And to break down that shame, if you're telling someone to lose weight or just do this or just do that, or you have the fear of sharing how much you're drinking because you're afraid of losing your employment, your kids, your friends, being berated more like I was from an intimate partner that was abusive. That shame is very deep. And the only way to get rid of shame is empathy. And as you're talking about allied professionals, those are the people, in addition to peers, that have that empathy. And I believe that it's very vital and critical that those roles become more important in PCP care, because the PCPs, this is where it's happening, right? This is where we need to stop. This is where the early intervention has to happen. If it's gotten to a hepatologist, most likely it's too late. So having someone that is there to talk about exactly what you were saying, Louise, to talk about the whys, to talk about what is going on in the person's life before you hit them up with what it is that they have and what it is that needs to be done, I think is just really a helping helping them to get on a path that is a path that can actually be a lasting lifestyle change instead of just a diet or something that they stay sober for a month and then they stop sobriety after that. It's got to be a change in their entire lifestyle. And I really do think an allied professional and having more time with an allied professional is a definite answer, as well as changing the way we interview patients as to what they drink, what they eat, and those types of things. I think that needs to be more motivational interviewing, which I think nurses are very good at.
Neeraj, anything to add or comment on?
Yeah, so I want to build a bit on that. And Louise, I want to invoke the good old NHS, where I had a chance to work in mental health. And I was a psychiatry medical officer, and I had my consultant who oversaw the unit, but we had a psychotherapist, we had a music therapist, an aromatherapist, an art therapist, we had the nurse, we had a social worker, and we approached the care of our patients as a team. And that was absolutely important. And I think the same thing applies when we look at diseases like liver disease, where it is social risk factors together with genetic and medical issues and all of that together. And we need a multidisciplinary team approach. Now, the big challenge we have in the United States, Roger, is that our remuneration for health services isn't structured in that sort of way. It's very individualistic by service, and the way we provide services isn't that way. And so we have to make a huge push to now start thinking about the patient care as a multidisciplinary team. And the PCP might be the quarterback that sort of coordinates that function. But when a patient sees a team behind them and they part of a team, that's when we start dismantling the stigma. And in addition to the professional team of medical and allied medical services, we also have peer networks of patients. One of the biggest things I've seen with behavior change is when patients start sharing stories with each other, and there's that sort of peer, I don't want to say pressure, but peer influence and advocacy that makes them motivated to achieve that change. We also have to ensure that those interventions that are being advocated for are safe, they're clinically effective and proven, but that's where the whole team approach comes in. And I think we need to start thinking through this. And the other important part about it is each touch of an allied medical discipline counts towards that sort of total package of care. Because when you look at the fact that the average consultation in the United States is about 6 to 8 minutes, how much care can be offered in that time? And so as we provide team-related services, we then have deeper and longer touches with patients that can sort of effect that change.
Can I add a little bit to that real quick? Is I just wanted to mention that there are models out there too. Like Michigan Medicine right now, they're doing a fantastic job with their main unit, which is an alcohol interdisciplinary unit where a person who's diagnosed with liver disease will see a hepatologist, a social worker, and psychotherapist all in the same visit. And so it is being done. And there are other organizations like the University of Pennsylvania and some others like the University of Wisconsin that has started piggybacking off of this model. And it's been highly effective. And so I absolutely agree with what Neeraj is saying, is multidisciplinary is the way to go. But at the PCP level, like Neeraj was saying, you need a team always as a patient, in my opinion.
So Louise, you wanted to say something and then I have a question, but why don't you go ahead first?
Yeah, I was going to tie in what Jenn had said earlier about being really ill and being at that stage of liver disease that was really, I suppose, frightening. It's a frightening stage to be at. And in hepatology, we are a team. We are the doctors, the nurses, the healthcare workers, down to the receptionists who know all of our patients, because we know our patients very, very well. They may not see a hepatologist every year, but the nurses will always keep in track because, as Jenn described, we do have a little bit more time within our calendars to be able to do that, which is why we work very well as an integrated team. It's using that integration to move to diabetology, cardiology now. They have expert teams as well who all know their patients just as well. We now need to know each patient's within that combination better to get more of a team. We're the Premier League because we're all together. So we bring more teams and more skill sets on now, and this is where we have to go towards the future of this multidisciplinary focused treatment and assessment of patients with a condition and an organ that affects all diseases. I've obviously done liver intensive care, so I've seen that end. So it's bringing that skill set. So tying that in, what Jenn was saying about, particularly at that frightening stage of disease, you need more than a team. You need an entire army of people behind you to help you. But all of the work, we support, we empathise, the work has to come from the patient. At every stage, all we can do is give our best. And that's what Allied Health do, along with our structures. But structure can get in the way of movement.
With all that in mind, I want to play back to you a point of view I sometimes get when I have conversations with people on these topics. And it starts with the idea that goes, at least in the U.S., the primary care practice is incapable of doing the kind of quarterbacking that you're talking about, right? You've got a 6 to 8 minute appointment contact, as you point out, usually, by the way, with about a 12-minute questionnaire, right? So if you speed talk and take all your answers in yes and no's, you might get it done. And without a lot of structure behind it, it tends to fall apart. So there are businesses raising large amounts of money right now in the belief that the solution has to be technological, that the integrators have to be technology, that the tools have to be for patients to be able to get what they need technologically. And I've got my own point of view about that, but I'm wondering where you see technology either aiding or working across purposes or even fighting against the kind of system that you envision building.
Okay, so I'll take a stab at that. In nearly every context, I don't think technology is the solution. I think technology is an incredible tool that assists us in many different ways, but in and of itself, it isn't a solution. At the Fatty Liver Foundation, for example, we've set up the Wellness League, which is an online portal where people can get on, have access to various services based on their zip code, find peer support, as well as like everything from recipes to how to live a healthy diet, etc., etc. And that's our sort of technological intervention that is enabling the human connection to service providers as well as a peer network. So I do think that's an example of how technology is a tool to create that enabling environment. I mean, when you really think about it, medicine can be a social science in that regard. So I think that human engagement and contact is part of the healing process from my experience. So it's not just about a technical intervention, but that connection that is available between people, that's part of the healing process. And if we can't get that through the PCP, we have to ensure that there's other ways as part of the transdisciplinary or multi-sectoral team that we are providing that high touch. And there's an incredible amount of research coming out where elderly patients in homes who are suffering from mental health challenges and mood disorders, all of a sudden their affect changes when they are young children visiting, or if they're given a pet to take care of, etc. And so we have a chance to now have both. So it's not either or, but it's how we use both to its greatest effect and impact. Using technology like electronic medical records can be a huge help in coordinating a multidisciplinary approach, but finding those soft touch factors that are an incredible part of the healing process is absolutely critical.
I'm just going to add something to that. You could be technologically rich or technologically poor. It is its own stigma depending on what your access is. And I think Neeraj was absolutely right there. Technology is not going to help in an older community. I checked into a hotel in Copenhagen. I couldn't book my breakfast via reception. I had to go online and book it through. My parents could not possibly go to that hotel because they'd never deal with it. And they're fairly techno-savvy. So you rule out whole areas of communities by depending on what technology you use. I think we have to come back to the basics. Education, education, education. The right part and the right path for each individual. I have technology. Some of it I like, some of it I don't like. But we can't make it so technological that we exclude people who are rough sleepers on the streets, who don't have a mobile phone or who don't have access because they're a low or middle income country to internet. So we have to be careful where we pitch our technology, and not everything's going to suit everybody.
And I agree with you, Louise, too. Accessibility is a very important issue, and one that I believe there are a lot of programs out there now that are trying to get people who are experiencing homelessness cell phones and trying to get to them the types of equipment they may need just to have internet access, so they could possibly join groups. Because the one part of technology that I really am happy about, and a lot of this came about because of COVID, is the ability for us to be meeting like we are right now. We don't have to be in a studio to get this done. Same thing is true for group support. So Sober Liver is going to be starting virtual group support systems, and those are going to be meetings that are online meetings. And we're going to be able to reach people from their hospital beds. People will be able to pull up their phone. If they don't have a phone, we'll get a hospital to supply a computer so that they can get online, so that we can meet them at their most critical point. And then as well, people can reach us wherever they're at to actually take place in one of these meetings because of technology. And we're looking at a platform right now to utilize this technology that's more secure and safe for some of our larger meetings, so that they can't be infiltrated by Zoom, but it's also a place where we can gather data so that we can have some evidence-based medicine to actually take to others and show that this is working, to show that groups actually work. And so with that, I think technology is going to be extremely helpful. There's also a lot of apps I know that are being developed right now to help figure out different ways of treatment for like alcohol use disorder, so that a person who may have kids and not be able to do an inpatient treatment, having places where they can go that are closer, and the ability to get there through an app and know where to find these things. And then the Wellness League is rich of information, not only all the wonderful things Neeraj mentioned, but also food pantries, transportation. It helps you get bus passes and other things like that it really helps people that are marginalized communities and people who are not as privileged as we are right now sitting here talking the way that we can talk.
So we could do this for hours, and this is a fantastic conversation. And the only reason it's going to stop is because it has to stop right now. I'd love to come back to it on a fuller episode, maybe with a couple of more folks who have different patient advocate perspectives. Sometime February, March would be my guess. One closing question. What do you see for 2024? From your part of the liver world, of the steatotic liver disease world? What are the things that make you optimistic? Are there any things that you see as possible storm clouds? What do you envision if we get together in 12 months, what will you be telling us this year, the upcoming year has been like?
I'll take this. Well, 2024 is going to be a big year for both Fatty Liver Foundation and Sober Liver, because we are just now starting this partnership, and we have so many opportunities now to go for different types of grants, to talk to different people, to do webinars, to really let people know about this nomenclature change and why it is so exciting and why it's going to be able to break down the silos that we currently have. And so my optimistic hope for 2024 is that we will be reducing and dismantling some of the stigma associated with these diseases, and we're going to come together more than separating apart. Unlike our country here in the US, I am hoping that we are combining and coming together versus floating apart. And then for Sober Liver, we're going to be starting a pilot program sometime, hopefully in the next few months, with different universities and institutions across the country to start developing evidence-based medicine on how group virtual programs work to help others, not only in the ALD or Met ALD space, but also for other liver diseases as well. So I'm very optimistic for our future. The only downside I could see is losing more people before we're ready to go. And because I really want to get this going. And I know every single day that goes by, we're losing more and more people. And so that's my fuel to my fire, is to get started as quickly as possible. And I really appreciate you having us, Roger. Thank you so much. And Louise, it's been a pleasure talking with you. And I look forward to talking with you again.
Great, Neeraj.
So my wish for 2024 is it needs to be a year of radical incrementalism. Okay. So we spent a lot of time on the analysis and the Delphi process and all of that to do the disease classification. Is it perfect? No. Is it workable? Absolutely. And we just need to put one foot in front of the next and try and figure this out. Perfection is the enemy of the good. And if we try to figure it all out perfectly, we'll end up doing nothing. So 2024, one foot in front of the next, and start building this.
Louise, I'm going to give you the last word on this. because it's your neighborhood. I'll just say this real quickly. I said this already. We could go on for hours. It's been a tremendous conversation. I appreciate both of you and the work that you're doing and what you bring to the liver field so much. It's uplifting to listen to. Jenn, I kind of feel like I'm sitting on the back of the flying turtle right now. And with that, Louise, last words all yours.
I suppose there aren't very many last words after everything that they've said. It just makes me feel even more empowered and invigorated when I hear the patient community and the sort of get together, empowered and move forward and really grab it by the scruff of the neck. The only way we're going to change it is if people who with the disease bang on the doctor's doors, whether it's a PCP, but we've got to find, we've got to locate, we've got to do it. And it's really just wonderful to hear the story, the combination, the combining and the removing of those stigma barriers. And I think I certainly have the vision of flying turtles, but turtles fly in the water. So it's perfect. And thank you both for joining us. And I'm looking forward to how it goes.
Thank you both so much.
And now for the Season 4 end-of-year episodes business report.
Slava Charini, Chayim Slava, glory to Ukraine, glory to heroes. And also Am Yisrael Chai, the people of Israel live. The last time I recorded a business section for this podcast, the U.S. Congress was delaying getting badly needed aid to Ukraine. The world was decrying the death of Palestinian civilians, while most were forgetting, and even worse, some were celebrating, the horrible rapes, beheadings, and other beastly crimes Hamas committed on innocent Israelis October 7th that precipitated the Israeli military action. I'd love to say that 3 weeks later, things have changed for the better, and there were days of hope in the Middle East during the Israel-Hamas ceasefire. But sadly, little is meaningfully improved. As we come to this holiday season, let's hope the Ukrainian military maintains and perseveres through the coming winter.